Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Today, we're diving into the fascinating world of dermatology with our distinguished guest, Dr. Tracey Vlahovic. Dr. Vlahovic is a renowned expert in the field of podiatric dermatology. She currently serves as a professor at Samuel Merritt University in the College of Podiatric Medicine, where she shares her extensive knowledge and passion for skin health with the next generation of medical professionals. With a career spanning over 2 decades, Dr. Vlahovic has made significant contributions to our understanding of various skin conditions, particularly those affecting the lower extremities. Her expertise covers a wide range of topics from common issues like hyperkeratotic lesions to more complex conditions such as psoriasis. Dr. Vlahovic is not only a skilled clinician, but is also a dedicated researcher and educator. She's known for her work in clarifying medical nomenclature, as you will see in this episode where she straightens me out, ensuring that we use the most accurate terms to describe skin conditions. This commitment to precision extends to her approach to diagnosis and treatment, where she emphasizes the importance of considering the whole patient, not just their symptoms. In today's episode, we'll be exploring several fascinating topics with Dr. Vlahovic, including the latest developments in treating psoriasis, the connection between skin health and overall wellness, and some practical tips for managing common foot-related skin issues. So without further ado, let's welcome Dr. Tracey Vlahovic to the Pod of Inquiry. All right, everybody. I am here with Dr. Tracey Vlahovic, and we're going to talk about some skin today. So hopefully everybody will have a little skin in this game, and we'll be able to have some fun. And so Tracey, thanks so much for coming on.
Thanks for having me.
Oh, you're welcome. You're welcome. It's an honor. Why don't you tell everybody a little bit about yourself so that the audience has kind of an idea of where you're coming from and the space that you're in?
Yeah. So I am currently a professor at Samuel Merritt University College of Podiatric Medicine in Oakland, California. I recently just began there, and the majority of my career I spent as a clinical professor at Temple University School of Podiatric Medicine in Philadelphia. My claim to fame is that I was the first podiatrist to do a fellowship in dermatology, and I did that after my surgical residency. So I had an attending who was willing to take me in and train me like he was training the other family practitioners and general practitioners that he would bring into his office. We would see everything in the office. And I graduated with that fellowship certificate. So that really helped me go on to become an educator. And I've been teaching dermatology ever since, both to students, but also to practitioners.
Excellent. So what was it that sparked your interest in derm?
So I have to say it wasn't the class.
Yeah.
When I was at my podiatry school at Temple.
Yeah.
In fact, the professor who taught dermatology at Temple was a very well-renowned professor, but sometimes that doesn't translate to teaching. And I remember sitting in the class saying, everything looks the same. Everything looks the same, right? That's what people always complain about.
Right.
So when I had my rotation as a first-year resident at St. Luke's University Hospital in Allentown, Pennsylvania, dermatology came alive for me. And all of a sudden, I was seeing these diagnoses that I had learned about, but just couldn't put a picture to a name.
Mhm.
And every day he would quiz me and say, well, what is this? And I was like, I don't know. He's like,
Right.
well, okay, look it up. And then the next day we'd see the same thing. And I was like, I know what that is. And so every day my confidence would get built up. And finally, at the end of that rotation, I was just in love with dermatology. And it was completely out of left field. Because
Mm.
as you know, most of us are going into it to become podiatric physicians and surgeons. So
Right.
all of a sudden I was like, I am passionate about this. Where can I take it?
Right. Well, and I think derm is very hard just from a didactic standpoint because you don't have the context of what's really going on, the patient interaction, these types of things. And I remember the old days, the saying was, well, derm's pretty easy. If it's wet, keep it dry. If it's dry, get it wet. And that's probably as far from the truth as anything you could imagine.
It is
um,
now.
yeah,
Yeah.
for
The
sure. And
paradigm has shifted.
yeah, yeah. And it's really amazing how these dermatologists they're detectives. They have to figure out some really cool things, and it's not it's not so easy. Let's put it that way.
Well, I always teach my students that dermatology is 10,000 diagnoses with about 3 or 4 medications to treat it, right?
Okay.
Topical antibiotics, topical steroids, topical antifungals, and things like that. So, um, it is challenging, but that part of me that is the detective that wants to really, you know, take in the whole patient, but also focus in on what is going on,
Right.
and dive deeper into that. That just appeals to me. So I always do feel that I am a detective
Right.
when I am seeing these patients.
We feel the same way in the peripheral neuropathy space because there is so much there that you feel like you're at a crime scene and you have to gather up all of the evidence and really try to put it together to figure out why they have what they have. And sometimes we don't figure it out and we just have to treat it, empirically. And
Yeah,
and then, if we get lucky and find the cause, that's great. It doesn't mean that we can't make people better, but there's always this disconcerting thought that I have. If I don't know the etiology of something, it bothers me. Rather than just treating a symptom, I want to treat really what the cause is if I can.
absolutely. I feel the same way. And there are times that the diagnosis is just not evident. And I'm very fortunate that my dermatology attending is someone who greatly thinks outside the box. And he really taught me to be creative, not only in treatment plans, but also in my approach. I am incredibly grateful that I had him as my teacher and mentor because it has allowed me to, think several steps down the road with a patient instead of saying, well, if this is the only way to treat it. No, there's going to be, if A path A doesn't work, there's going to be C, D, E, and F. And,
Right.
that's, something that has really defined my career.
That's very interesting. So we're going to talk about psoriasis, but before we get to that, we had a little bit of a discussion before while we were trying to arrange our times and whatnot with this conversation about nomenclature. And so this will be the last time I say this word because I promised you that I would henceforth I will always go forward with the newer nomenclature. But talk about porokeratosis, which is not the correct nomenclature. So let's talk about that just for a second. Tell us what the new nomenclature or the correct nomenclature is, and then how the hell did we get it wrong for so many years? Because I know we've got the same problem with Morton's neuroma because it's not a damn neuroma. So and I've been barking up that tree for 30 plus years. It's like, let's call it a pinched nerve or an entrapment or anything, but until you mess it up and cut that nerve or destroy it somehow or try to destroy it, it's not an aroma. So, but let's get to porokeratosis. How did
Yeah.
that get ingrained?
First of all, I'm happy to meet someone who's as passionate about nomenclature as I am because it's not only important from a communication standpoint, but also medical legal. And in
Right.
this case, medical legal. So, from what I understand, years ago, they looked at a lesion on the foot under a scanning electron microscope and said, this looks porokeratosis like.
Okay.
And all of a sudden it developed into, porokeratosis plantaris discreta, right? It's
Right.
that discrete lesion. However, an actual real porokeratosis, if I were to say that word to a dermatologist, it would mean something very different. From a histological standpoint, there's something called the cornoid lamella, which surrounds it. It is usually an atrophic center. And there are about 4-ish types of porokeratoses, real porokeratoses. These all have gone on to become, or have the potential, I should say, to become squamous cell carcinoma.
Oh,
So
that's very interesting. So
yeah,
it's a precursor then to squamous cell,
it can be,
or it could
exactly.
be. Right.
And even the punctate, the true punctate porokeratoses that we could see on the foot or even on the hand has been shown to go on to become skin cancer. So it's really relevant that we are clear about this nomenclature so that if we actually have a porokeratosis, we treat it. And it would be like treating anything else that is precancerous, like an actinic keratosis. So it's something that I'm very passionate about because we throw around the term porokeratosis, but the problem is that we're talking about a benign punctate keratotic lesion on the foot. There's nothing to do with the actual real porokeratosis. So I'm very, very passionate about changing our profession's way of stating this because it's just, to me, it's, again, it could be a medical legal issue. So let's try to prevent things before they happen.
Well, I think that, I was, involved in this nomenclature issue with Morton's, and we actually published an article, I think it was about 2005, and it was important because not only is it a medical legal issue, but the way something is named inspires people to treat things maybe one way versus another thing, right?
True.
So, if it's this quote neuroma, oh, we have to cut it out. We have to do a nerve transposition or something like that versus no, if it was just an entrapment, then it would give a different conceptualization to the practitioner. So I think there's that too that's important. So are we supposed to call it a punctate hyperkeratosis?
You can call it that. I mean, we don't have any definitive true nomenclature for what we have, but what I call it is a punctate keratosis, a punctate lesion, a punctate hyperkeratosis, just describing purely what you're see's.
Right. And most of the time, those are associated with underlying biomechanical things, correct?
Right. Yeah.
Right?
And absolutely. And there's certainly a whole version of them that are more genetic, which are part of the genodermatoses family. So if they're isolated, I call them punctate keratoses. If I see a cluster of them and we know that the patient has had them since they were young, then it's a genodermatoses, meaning it's something you're born with.
And is the general appearance of a true porokeratosis vastly different than what we're used to seeing as this hyperkeratotic punctate lesion?
So interestingly enough, it would be really difficult to tell apart the punctate keratoses that we call a porokeratosis versus a true porokeratosis. The only way you'd know is if you were to take a sample of it and look at it histologically, because it has to have that cornoid lamella as a defining factor. So it has to have that histologic phenomenon. So it's one of those things where really would be really difficult to know. So that's where if somebody wanted to biopsy, it would be completely warranted.
So let's get into that a minute, because this could have some very important ramifications for your average podiatrist that's out there. If it's the more of the biomechanical lesion that we're used to seeing, that's probably going to be submetatarsal heads, that area there. Is there a decent incidence of true porokeratoses in the foot?
So it's not as prevalent as I would say an IPK or intractable plantar keratoses or a true punctate keratoses. And actually, I'm glad you brought that up about the mechanical lesions, because in 2024 and in 2023, some articles have come out regarding IPKs and wart.
Okay.
And so there's actually a lot of the things that we call IPKs are warts.
Mm-hmm.
And so there was an article that came out that they did a punch biopsy which I'm not advocating everyone go and do a punch biopsy on these lesions. But certainly if you're treating and it's not doing what it should, then there's a reason for that. And that warrants it. But they did a punch biopsy on lesions that they called IPKs, and then they did PCR analysis on them. And 68% of them came back as warts.
So it in that 68%, then that verruca manifested as a punctate lesion, or was the punctate lesion there and then got some verruca into it?
And that's like the chicken and the egg, right? Which came first.
Right.
So there are certain warts where we don't see the, punctate bleeding or anything like that. They just don't manifest that way.
Mm-hmm.
So it could have been a mechanical lesion that, the virus came into. That's entirely possible because the HPV just needs a break to get into the basal keratinocyte. Or it could have been a wart that's just on the older side. Sometimes older warts are not manifesting as visually clear as a younger wart. So it could be either way, and that's something that has to be determined. But it's something I've always suspected in my own practice because people would come in with IPKs. And, I would look at it with my dermatoscope. I have a dermatoscope. I always say it's my best friend. It's my only friend. It's the only one who would tolerate me talking about dermatology 24/7. And it would, by dermoscopy criteria, it would be an IPK. But I would treat it as a wart because these patients were coming in because it was uncomfortable. It was painful.
Right.
And it may or may not have been in an area that mechanically made sense. But they would get better. And I actually did a little study with the microwave therapy and using the microwave, which is meant for warts, on some IPK patients. And the lesion didn't disappear, but their pain basically vanished.
Right.
And there was a study that came out from England about the microwave and IPKs as well. So my observations were definitely shown to be true with their study. So it's interesting because what we're calling punctate keratoses, formerly known as porokeratoses, are they warts, really? Mm-hmm. Are they IPKs? Are they a little of both? That's something that certainly warrants more research.
Yeah. So what about treatment? Because in the old school, you were told that, and I don't think this is true because of my own clinical experience, albeit very small in the derm world. But in the old school, you were taught, well, if it's a porokeratosis, and I'm using that word incorrectly now, but if it is that, you're never going to get it better unless you do something to alter the mechanics of the shearing forces that are going on in there, whether that be offloading it with an orthotic device or a partial met head resection, or, God knows what, right? But yeah. So what's your take on that? On that?
So for me, I'm going to look at where it is, right? Mechanically, is it on a weight-bearing surface or a non-weight-bearing surface? What's the level of pain that they have? Is it something that I can offload and treat as well? Or is it something that is purely just mechanical and just offload and not treat as a wart as well? So there are at least a lot of different products that are out there that can be used off-label for these lesions. So for instance, I will use adapalene gel quite a bit. It's now over the counter. There is still a version of it that's prescription. I will use 5-fluorouracil quite a bit because it's helping to change that cellular turnover. I will even use, again, the microwave device because the microwave is meant for warts, but it's doing something to the nerve endings in these lesions. So it's deadening them possibly, who knows? But at least if I can control what that patient's symptoms are, which if it's pain, that's great. Then I'm doing what they need me to do.
Right.
So I look at it as multifactorial. What's the patient's complaint? Where is it? And, how can I treat it the best way to resolve that?
Yeah, and so what's your thoughts on like cryoablation or even laser for them?
So cryo, I've never had success with because the skin is so much thicker planarly.
Mm,
And in the dermatology office, we froze everything, right?
right.
And patients would come in every 2 weeks for a year and their lesions weren't resolved.
Mm,
So I personally don't use cryotherapy very much at all in my practice for warts. I can use cryo for other lesions to destroy other lesions, but for warts as a singular monotherapy, I just don't see the utility of it. But for laser, I will use laser in these patients. I often will not use laser as a first line. I
mm,
will use it after trying something else. So, because laser, it can be very uncomfortable. It for some people there's no downtime, and for some people there's
right.
significant downtime depending on which laser you use and what energy you use and how and where it is. So it's one of those things where I have definitely used laser my whole career. Cryo, not for warts or IPKs or any of these lesions, but for other things. Yeah.
Right, right. Um, so we were going to talk a little bit. Well, I guess we've kind of beaten up the hyperkeratotic punctate lesion now. So notice how I got that nomenclature
I love it. That's great.
pseudo correctly. It takes
Yeah, I say punctate keratosis.
punctate keratosis. I mean, you got like
Simple.
35 years of crap up there in the brain, and so it takes a while to get it cleaned up and reassembled. But we're going to talk about psoriasis a little bit. So let's go into that. I mean, there's a lot of people running around with psoriatic lesions.
There are. I am extraordinarily passionate about treating psoriasis. And part of it is it goes back to my dermatology attending, Dr. Steven Schleicher, because he's considered one of the key opinion leaders in the psoriasis world. So I saw people coming in for full body phototherapy and going on biologics. So for me, treating these patients with plantar psoriasis is such a satisfying thing, because if I can get them to where their quality of life has improved in any way, then I feel like I've accomplished something. These patients come in with dry, cracked feet, extreme redness. The fissures are really what is the most painful to them. They can certainly have a lot of pruritus as well. But I will often start with topical medications. And if that doesn't do what I need it to do, then I will move on to systemics or biologics or phototherapy. So there is a stepwise approach to it. And it can be very frustrating for both the patient and me until we find that sweet spot of what treatment is effective for them.
I'm sorry to interrupt, but before you continue with this great conversation, we need to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once released into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co and use the code SBPOD to get a 15% discount off your first order of Stem Regen. Let me interrupt you there because you brought up a really good point. A lot of times people don't think about skin lesions as impairment. I mean, they will like, oh, I don't like the looks of it. I mean, look at the surface of my knees. It's all kind of funny looking and all this other stuff. But if you have something on the plantar aspect of the foot that fissures all of the time, that's going to impair their day-to-day walking activity, overall health ramifications from that, which are pretty incredible. And I think something that kind of illustrates and really amplifies that point with me were how many people in World War II were sidelined by trench foot. It was actually I believe it was a higher incidence than people that were actually killed in battle. And it was a very serious thing. They'd end up with secondary infections. They were out of battle. I mean, and it's just it's just a rash on the foot. Well, no, it's a lot more than that.
It's a lot more than that. I always encourage people, and this is where that detective sense comes in, ask the patient where else they have a rash. They might have psoriasis only on their scalp, or maybe they've had something on their hands. Patients often don't correlate or don't think things can happen on their feet that happen anywhere else. So that's an important point. But also, I see so often these people being treated as having a fungal infection. And people will swear up and down that this patient has athlete's foot. And I'm like, that is not athlete's foot. I promise you this is psoriasis. Right. And there's different versions of psoriasis. There's plaque psoriasis, pustular psoriasis, things like that.
Right.
And pustular psoriasis, or some people call it palmar-plantar pustulosis, there's different terms for it, can be very challenging to treat. And but that impairment, people miss work for it. They will go on FMLA, a disability, because they can't work, especially if there's somebody who works in a warehouse or as a bank teller or a teacher, someone who's on their feet all day. You've no idea the impairment that those issues are causing on their feet. You know, I always show my students a picture of somebody with psoriatic or palmar psoriasis on their hands. And I'm like, imagine if you were a surgeon. Right. And you had to scrub your hands, you had to use your hands all day to do all the things that we do. How would you feel? Well, now extrapolate that to the feet and you're standing all day. So it again, if I can get those patients to a place where they can do the activities they want to do. For instance, I had a woman who she said, all I want to do is take walks with my husband after dinner. We're trying to lose weight together. And once I was able to get her feet as in remission as I possibly could, she was just like, I'm just so happy that I can walk with my husband. Yeah. It's the simple things in life that we who don't have that take for granted.
Yeah, absolutely. People don't realize how much of a problem something is until they have it.
Exactly.
You know, and it's like, wow, I didn't know there were this many people suffering with this kind of a situation. But let me get back to that, because some of the things that I was reading the last week or so, trying to get ready to have a chat with you, there seems to be a component of psoriasis that's affected by environmental triggers as well. That there's maybe a basic genotype that's going on, and then all of a sudden you pile on an environmental trigger. Could fungal infections be an environmental trigger? Because I know there's no rule that says a person can only have one thing at one time.
Absolutely. And that's another fallacy that we have, especially in podiatry, is that it's only psoriasis, it's only this. I have to tell you that one of my favorite things to treat is what we call secondary onychomycosis. And what that is a patient who most likely has psoriasis first, right? They have psoriatic nail disease, and maybe they have some skin issues, maybe not. It's not always prevalent with the nails, but then they have onychomycosis on top of it. So and one of the things, again, very passionate about is nail psoriasis and onychomycosis look virtually identical. I've been, a practitioner for over 20 years. I can't definitively walk into a room and say, that is nail psoriasis, that is onychomycosis, because the nail can only manifest disease in a finite number of ways. So we have to get it out of our heads that every nail that has subungual debris, onychal lysis, and discoloration is fungus. It can very well be nail psoriasis. And in some cases, the two live together. So in those cases, the only way I'm going to know this is to do some sampling and send it to a lab. Know that I'm going to, get positive dermatophytes, but also if I do a PAS, it might say that there's parakeratosis or other histological findings that are very prevalent in psoriasis, and say, okay, all right, I'm dealing with both. And I'm going to treat that fungus first and then the nail psoriasis, because the fungus is going to be a little bit easier to treat than the nail psoriasis.
How common is it that somebody can have a psoriatic manifestation that appears like an onychomycosis, but not have any other systemic signs of psoriasis?
Well, a lot of times nail psoriasis is indicative of psoriatic arthritis.
Okay.
So the only way that you might know that they have psoriatic arthritis, besides them
clubbing of the digits or something.
Pain. Well, and that comes later, right? So you don't always see the dactylitis or the clubbing of the digits. You might see just the nail changes and some isolated joint changes that maybe they just thought was wear and tear, and just, I'm older and I'm achy, right? But when you start to calculate, well, what joints are the problem and how many are there? And then looking at the nails and then saying, hey, do you ever get any flaky skin on your scalp, or maybe on the top of your butt or around your belly button, or, even around your ear? And they're like, yeah, I think I have some around my elbow. And you see that there's some psoriatic patches, but they're just, again, not very fulminant that it concerned the patient. And you're trying to put everything together and saying, I think I'm dealing with psoriasis here. And this, would make sense. And going from there saying, all right, this is probably a manifestation of underlying psoriatic arthritis.
Very interesting. And I'm going to ask the same question again. How common is psoriatic arthritis without any skin manifestations?
I can't give you numbers that I'm not good with that. Because
give me an estimate. I mean, we don't have to have an exact number, but is it common or not common, or?
Well, let me put it to you this way. So I see a disproportionate number of psoriatic patients in my practice versus maybe the average podiatrist.
Right.
So my numbers are going to be very different than what somebody in a regular private practice. So I have to say that as far as pure psoriasis, like just plantar psoriasis, without that, they might have some manifestations on their hands, but nowhere else, and that's palmar plantar psoriasis. I would say that's the majority of my patients.
Okay.
So that would probably be about maybe 75%, right?
Okay.
And then I will have the plantar psoriasis patients who have it on their legs and other places, and that they're like, I've had it where patients are about maybe 80% of covered in their body. And it's wild. Their whole body just has psoriatic lesions. That's a very small percent. Then there are patients who manifest just the psoriatic arthritis with the nail, usually just the nails, and maybe an isolated skin patch here and there, or maybe nothing.
Okay.
And that might be about 10%. So it's definitely skewed more on the full presentation of the skin. And one of the things that's interesting about psoriasis is you could be covered in psoriatic plaques and not have any manifestations of psoriatic arthritis. Like you don't need the severity of what's going on with the skin to dictate what's going to happen with the arthritic component.
What do you think's going on with the pathophysiology there? That there's just some predilection for epidermis dermis versus an arthritic joint? I mean,
so it's a full body inflammatory cascade.
Right.
So the pathophysiology of psoriasis, like it's so complex, all the interleukins, all the different things that people are targeting constantly with the biologics, and trying to find that sweet spot of which cytokine cascade can we stop so that we can help people both with psoriasis and psoriatic arthritis versus one or the other. So it's a really kind of complex but fascinating cascade to look at. That isn't just affecting the skin; it affects the whole body. And so one of the points I really bring home to my students is patients with psoriasis don't just have skin or joint disease; it's full body. We call it the metabolic syndrome, right?
Right.
So these patients, when I was in Philadelphia, about a mile or two up the road at University of Pennsylvania, those dermatologists wrote a seminal paper about how patients with psoriasis are more likely to have a cardiac event than someone without psoriasis. So that inflammatory cascade is impacting every organ, not just the skin and the joints. So it's going to increase possibly their risk of a cardiac event. We see a lot more depression in these patients, and that's fulminant with the skin issues and the pain in the joints and the itching. We see alcoholism increase. We see even suicidal ideations. We can see hypertension, all different kinds of manifestations because it's all throughout the body. So when the biologics first came on the market, my first thought was not only, wow, this can really impact these patients' lives with their skin, but how are we impacting the metabolic syndrome? Right? If we're decreasing all of that or dampening that inflammatory cascade in the body, how will this affect them long term as far as reduction of cardiac events and high blood pressure and things like that? And ultimately, if you feel better about your skin and your life, will that also impact your possible depression? So, it's a very complex cascade that's just amazing.
Well, and I think this illustrates a lot about human physiology, and that is that everybody talks about these very discrete biochemical pathways, and they're not discrete. They interact with all of the other ones, and that's why there's probably not going to be a cure or a drug for Alzheimer's disease, is because you have all of these things going on. Is the incidence of psoriasis higher in folks that are obese versus non-obese?
So again, it's the chicken or the egg situation here. So if you have, say you have plantar psoriasis, well, you're not going to be mobile, right? It's not going to allow you to maybe do the activities that you wanted to do. So your risk of obesity increases. That said, again, someone who isn't mobile, and they have there's a genetic propensity to develop psoriasis, and yeah, there is an old like when we're older, there's a version of it too. So does that influence it? And I certainly think if you have the genetic predisposition to have it, having a higher BMI is not going to be your friend.
Well, the reason I ask that, and I think you make a great point about chicken and the egg, which came first. Obviously, if you have an impairment in the foot, it's going to decrease your exercise, your activity, all of that. I get that totally. But what I have seen clinically in folks that have had weird unexplained neuropathies that we've tried to, get them to adopt a non-inflammatory diet. And interestingly, they will come in after, if they're compliant, and very few of them are willing to do that. But some of them are just so desperate, they'll say, yeah. And they'll come in and they'll say, yeah, my neuropathy's better, but man, my skin looks better. I don't have the seborrheic dermatitis all the time that was driving me crazy. And so I have to think that there's a lot of environmental things going on because we have so many bad things that we're putting into our body on a daily basis, like seed oils and all kinds of very inflammatory things.
It's also our gut microbiome,
right?
We a lot of us truly believe our gut microbiome influences how our skin is responding. I have encouraged patients over the years to find the diet that's better for them, whether it's a whole food plant-based diet or, the Mediterranean diet or what have you, so that you can change their microbiome and ultimately change their skin. every year stuff comes out. Is dairy bad for you? Is it going to increase your acne or things like that? A lot of people feel, in the realm of that dairy has a lot of hormones and it's not meant for us, right? So our body is like inflamed when it gets it, and that's going to impact our skin. So, again, I'm not advocating any of that right now. I'm just saying these are things I've seen work and not work as
Right.
well.
Right.
So, but I do believe the gut microbiome and the skin microbiome truly plays a role in the manifestations of these skin diseases.
Oh, I think there's no doubt about it. I mean, there's more serotonin made in the gut than in the brain, So, no, I guess my point is that we have been trained to treat symptoms and not treat humans.
Right.
If you make the human more healthy, a lot of the symptoms go away. Maybe not all of them, but many times some go away. I was just wondering, if you have somebody that's in, let's talk about a real severe case. They've got psoriasis to the point they can't even walk.
Yeah.
Do you look at their biomarkers and see how, do a cytokine panel on them, see where they are from an inflammatory standpoint, what's their homocysteine, all these things that are going on. Is that kind of it? Because the way our model of healthcare is right now is that it's hard to do that because you only have so much time in a day.
Right. Patients are coming to me and they want an answer and they want to be treated yesterday.
Right.
That's how it goes. So am I doing all those panels? No, I'm doing it. I'm looking at that patient saying, you need something systemic, right? I need to put you on a biologic, and I'm going to do all the blood work that is necessary for the patient to go on that, to make sure that they're the right candidate to go on that and that their history makes sense to go on that medication as well.
Right.
So that's more of where I go to, but I do talk to them about stress reduction.
Mm-hmm.
Because if we can, and that's something as Western trained doctors we don't often consider, is the role of stress and the skin, right? Especially, not just psoriasis, acne, everything, right?
Right.
Importance of sleep cycles.
Mm-hmm.
Those are all going to impact how we function. So, depending on the patient's background, I'm like, if it means praying, meditating, sitting silently and doing breath work or breathing exercises, these are all perfectly good things to just calm yourself down, calm your system down. It will help you and help your skin ultimately if you can find that point of quietness or zen.
That's a good point. When this episode airs, the episode probably one or two episodes before this, I had Jim Anderson on, and Jim he's a podiatrist, specializes in lower extremity peripheral neuropathy, and he does really wonderful work. But he did a study with vagal nerve stimulation and cytokine profiles before and after. And it was fascinating to see what he was able to show, that after 6 weeks of vagal nerve stimulation, it reduced the inflammatory cytokines and upregulated some of the anti-inflammatory cytokines. And so what you say it's just like diet. All these things are woven together. And there's no doubt that, stress exacerbates these conditions. But until you see a study like that, it seems kind of woo-woo. That's like, you just got to do some breathing and, mellow out and all this other stuff. But if you show somebody that their cytokine panels have changed from this vagus nerve stimulation, and you can do that with what we're talking about right here, that's a very powerful thing. It was a very powerful thing for me to see these, my God, these panels changed from vagal nerve stimulation. That's kind of crazy, isn't it?
It is. There was a JAMA article years ago, it's probably close to 20 years ago, that they did biofeedback and wounds. So they had patients who had diabetic wounds and they hooked them up to a biofeedback machine. Now, I had been unfamiliar with biofeedback until I did the rehab rotation in my residency. So one of the rotations I had was at the Good Shepherd Rehabilitation Hospital in Allentown, Pennsylvania. And that was a fascinating rotation because we did prosthetics clinic. We looked at CRPS patients, and they had a whole program, but they let me hang out in the biofeedback lab one day. And I'm like, well, what's this for? And they're like, well, mostly migraines, but we can use it for other things. So this particular JAMA study, they hooked patients who had wounds to the biofeedback machine, and they taught them that, when you feel your heart rate go up, or you're sweating, or these various like markers, to, to know how to control that. And those who were able to do that with the biofeedback actually had better wound care outcomes and wound closure outcomes. So it's not, we can show them the blood work, but we can also say, hey, there's research out there showing that if we're able to kind of calm our stress levels down, that our body's going to function better.
Yeah, and then the poor person that has this severe manifestation of their psoriatic disease, they're going to be more stressed. It's
Absolutely.
it's this catch-22 that keeps spinning around and around.
It's one of the skin diseases that causes the most missed days from work than anything else.
Wow. So I was gonna ask you, because we talked about triggering events and everything like that. Is there any evidence or indication that a contact dermatitis can fire up a psoriatic episode in patients? Because patient may come in and they say, I was doing good, but then I got these new work boots and I sweated a lot. And do you see that?
So I have seen that with contact dermatitis. Yes, that it exacerbated psoriasis. And one of the reasons for that is, so there are two different physiological mechanisms that are going on, dermatitis and psoriasis. They're completely different pathways. But psoriasis has this issue called Kebner phenomenon.
Mm-hmm.
So that's if we irritate it, whether we scratch it or do something to it, it gets worse, right? We get a sunburn, it gets worse. So an inflammatory issue like a contact dermatitis has the potential to make psoriasis worse if it's present, right? Also, I'm very anti-duct tape when it comes to warts. Like, if you actually go back and read that article, it is a terrible article. And they proved in subsequent articles that moleskin was, going to do the same thing, and it's just not that effective. So if you put duct tape on a patient with a wart who has either dermatitis or psoriasis, you could be causing some issues. Dermatitis because they could be having a contact dermatitis to the adhesive in that. Psoriasis because, again, you could be inciting the Kebner phenomenon. So I really caution people to just not do things willy-nilly because it sounds good and because Dr. Google says to.
Right. Well, there's a lot of crazy stuff that we do for, probably ridiculous reasons. And then somebody comes along and dispels that dogma and they go, oh, why was I doing that? That's pretty crazy.
That happens in medicine all the time, right?
Right.
We pass these myths down from one practitioner to another, like betadine, allergies in shellfish and things like that. Like, that's been shown in literature multiple times that they're not the same. And yet everyone's like, oh, you have a shellfish allergy, no betadine for you.
Oh, well, see, now that's a great little clinical nugget, but you hear stuff so often that if it's said 10,000 times, it must be true, right?
Exactly. Yeah. And we are to blame for passing it down. But then like a lovely little article will come out and it won't get that impact. It won't get that reader impact. And then it just kind of dies, right? Until somebody like me finds it, or one of our students or residents find it. And they're like, wait, look, this goes against the grain. There's no correlation between these two things. So why are we keeping on with the myth?
Right.
And that goes full circle back to the porokeratosis, right?
Exactly.
We are blamed for pushing that term over and over again in our profession, when all someone had to do is say, what's a real porokeratosis? Like, what's the actual definition of a real porokeratosis? It's not what we talk about in podiatry.
Right. Well, and you will see that in some other examples of that, how things are called one thing in neurology, and they're not called that in, orthopedics or podiatry. So it happens. And some of it, I just think that we don't, and I'm not saying you and I, but I'm saying as a general whole, we don't read other literature. Now I do, because I steal stuff from everything I can steal from upper extremity, that type of thing, because I want to read other opinions on it. But a lot of times people will get in their trench and they'll never read anything outside of their specialty. And there's
Right.
so much out there in other specialties that has translation to what you're doing, regardless of what your specialty is.
Oh,
That
absolutely.
it's a very valuable thing to do. And it's also quite interesting.
It is. Like, for
Yeah.
instance, one of the nail diseases that I am so passionate about is called disappearing nail bed. And it was coined by a dermatologist out of Mississippi, Dr. Ralph Daniel. It's something that you and I have seen our whole career. We just never named it. He named it. And it makes sense. And I now, whenever I am talking about nail diseases on the podium or to my students, I'm like, disappearing nail bed, you're going to see this, but there's a
Right.
name for it. And we should have been the ones to coin it, because nails are our bread and butter. But
Right.
I'm so grateful that Dr. Daniel did, because at least we have the literature out there to start that process of putting a name to a disease.
Right. It's very interesting. So Tracey, this has been fascinating. I think that we're going to have to come back again, because you've got such a wealth of knowledge. Our audience just is starved for this kind of interaction and conversation. But how can folks get a hold of you if they want to, catch up on things or some of the stuff that you think is really interesting? I know you've got a pretty good social media presence, so tell folks how that they can get a hold of you.
Yeah. So, I'm going to be starting a website of articles and blogs and things like that. So watch out for that.
Great.
That's going to be starting. I have also written blogs for Podiatry Today, which are readily available. I've done lots of press work for, journalists over the years, but I've also written 3 textbooks. So I've written 2 textbooks that are mainly lower extremity dermatology focused, and one on onychomycosis, which is one of my passions. So, there's definitely ways of finding me, but I'm going to try to put everything in one place eventually and have my own dedicated website where I can assist both people in practice, but also lay people as well.
And they can probably find you just by looking up at Samuel Merritt now. And if they want,
exactly.
shoot you an email or something, it's like, hey, I've got this weird case. Take a look at it.
Yeah, I can certainly talk to doctors, but I can't manage patients who aren't my patients.
No, I get that. But there's a lot of power in consultation between specialists.
Absolutely.
Yeah.
And that's something that happens to me every day starting at 6 a.m. So
Right.
I
Yeah.
get a lot of emails and stuff from people all over the United States.
Well, thanks so much for coming on the show. It's been an honor for me to learn from you, and I look forward to having far more discussions with you.
Well, thank you so much. I really appreciate you inviting me. It's been such a pleasure and so much fun to talk to you.
Thanks.
Have you been diagnosed with a Morton's neuroma? Are you suffering from persistent pain in the ball of your foot? Does it feel like you're walking on a pebble or a rolled up sock, even when there's nothing in your shoe? You might be experiencing Morton's neuroma, a common but often misdiagnosed condition that can significantly impact your quality of life. But there's hope. The doctors at U.S. Neuropathy Centers, under the direction of Dr. Stephen Barrett, the inventor of this endoscopic technique, offers a revolutionary solution: in-office, minimally invasive endoscopic treatment for Morton's neuroma. For years, patients had limited options for treating Morton's neuroma. Traditional surgery often meant long recovery times and potential complications. But with our advanced endoscopic technique, we're changing the game. Unlike traditional open surgery, U.S. Neuropathy Center's minimally invasive approach means pinhole incisions, less pain, faster recovery, minimal scarring, quicker return to normal activities. Our goal is to get you back to doing what you love, pain-free. With this procedure, most patients experience significant relief and improved mobility. Don't let foot pain hold you back any longer. Experience the difference with U.S. Neuropathy Center's minimally invasive endoscopic treatment for Morton's neuroma. Take the first step towards a pain-free life. Contact us today for a consultation. Call now 404-208-9892 or visit our website. Your feet will thank you.
I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only. It does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.